Hi, I'm Dr. Stephen Schendel. I'm sorry I can't be present in person to give this lecture today, but I think you'll find the contents interesting anyways, especially if you have a child who has an abnormal jaw or some type of problems of breathing. Thank you. This lecture is about hemifacial microsomia, mainly a comprehensive diagnosis and treatment for the skeletal deformity and the associated functional issues. As you know, the condition can be unilateral or bilateral. Here's a picture of a unilateral condition for this young man with associated microtia and a lack of the soft tissues on the involved side of the face. Treatment of the skeletal deformity is dependent upon several things. One, the initial airway in a feeding assessment. If a child is having breathing issues or feeding issues, then the deformity should be addressed earlier. We also categorize the skeletal deformity based on the types, 1, 2A, 2B, or 3, indicating the severity of the condition. And a comprehensive diagnosis would include not only the skeletal and dental, but as you can see here, the microtia, the soft tissue, whether there's a lack of subcutaneous tissue, or microstomia, which is an enlarged mouth, period. A number of articles have been written about this. One of the most comprehensive analysis systems is the SAT system by David, which has S qualifying the mandible condition and various classifications from 1 to 5, as you can see here. The most severe involving not only the mandible, but orbital component in the maxilla or the upper jaw also. The jaw condition typically, as I've said, is broken up into different types. Type 1, as you can see here on the left, all the normal components are there, and the mandible is just slightly smaller than ideal or the normal opposite side. In a 2A, we can see that the ramus, or the vertical portion of the mandible, is reduced as compared to the dotted line, which indicates the normal size. And in type 2B, this reduction is even greater. I haven't illustrated type 3 here, but as you can imagine, the half or more of the mandible on the involved side is missing, so it's the most severe type. Under the SAT multi-system classification, ears are also classified under A, and as you can see, there are different types, and reconstruction is possible. That will be talked about by another one of our speakers, so I am not going to delve any more into this condition at this time for you. Also under the SAT system, the last is the soft tissue, as I mentioned, and there could be no contour defect, which is the minimal T1, or a nerve involvement, to T3, where there is a hypoplasia of not only the soft tissue but the nerves, and also the involved muscles to the jaw and face in this airway. One of the key studies that we get anytime we feel there is a breathing difficulty associated with the small mandible is a polysomnogram. If your child is snoring or they have gasping type of breathing episodes at night, or are very tired or hyperactive, then the polysomnogram should be done. In an infant, the RDI, what we call respiratory disturbance index, or number of events, should be around 0. In other words, an event is when you stop breathing or you have a shallow breath. And oxygen saturation is also measured. It should be over 95%. And a normal pH probe. We also look at the stages of sleep, and we like to see, especially in children, a normal percentage of REM sleep, which is around 25%. This is important because growth hormone is only made in a REM sleep, and if children do not get enough REM sleep, they have less growth hormone, and they tend to be smaller children than normal. Of course, what we're worried about with the polysomnogram is obstructive sleep apnea. The abnormal study will indicate that this is a condition that we need to address as soon as possible. Again, it's associated with small children, failure to thrive, and also GERD, or gastroesophageal reflux. I see many children on therapy for this with antacids, And the real cause is the obstructive sleep apnea. If we get rid of the cause, then we don't need to medicate for a condition. Also, it has been associated in a number of articles of poor school performance with obstructive sleep apnea in children, many children performing at grade level lower than they should. So how do we break this timing up depending upon age? Early treatment is between 0 to 2 years of age. This is when the macrostomia, or the lateral facial cleft, would be repaired, skin tags removed. Jaw distraction would be performed to make the mandible larger and of a more normal shape. If it's a type 3 condition, for sure. And in many of the type 2 conditions, as I've shown, if there is obstructive sleep apnea associated with the condition. The intermediate treatment level is 4 to 8 years. Here, a microtia reconstruction would be initiated, and again, that's going to be covered by other speakers. Soft tissue augmentation is frequently done, if needed at this time, by fat transfer, and distraction of some of the type 2 jaws. It's preferable if the mandible is small, the lower jaw that is, that the distraction be performed while the face is growing vertically, and that is in the area of 7 to 9 years of age, in preparation for later surgery if needed in adulthood. Late treatment is that greater than 12 years of age and may include occasional jaw distraction, but in many cases orthognathic surgery, which is the final treatment to reposition the jaw and teeth if needed, and perform a chin if also needed. Soft tissue augmentation is done at that time by fat grafting again, or other procedures. And occasional children will need nasal surgery, which is known as rhinoplasty. Again, this would be the last stage of treatment after growth and development is completed. Here you can see a young child who had type 3 hemifacial microsomia when we look at the mandible, with severe obstructive sleep apnea. Again, you see there's associated microtia on the right side of the face, tissue tags, and a lateral facial cleft. There's also tissue tags on the left side of the face, which is an indication that this is probably a bilateral condition, even though the mandible on the left was a fairly normal size. The polysomnogram in this case demonstrated 61 obstructive episodes for this child, the longest of 12 seconds, with oxygen desaturation to 82%. That's not something we want to see in any child. The AHI, or the apnea hypopnea index, remember, should be around 0 to 1 or 2. It was 27 in this child's case, indicative of severe obstructive sleep apnea. If we look at the CT scan, you can see again that the right side and the lower left-hand corner, has a very small mandible. There's a very little condyle, or the articulating point, and a lot of the other pieces of the normal jaw on this side are missing, especially when we look to the right side where we can see a normal jaw structure. What happens when the jaw is short and parts are missing, is on the right side, is that the jaw drops backwards because it has no stable position. And when this happens, the tongue also drops backward, especially when the child lays on their back and falls to sleep. And this results in obstruction of the airway, causing the symptoms and problems that we've just mentioned. What do we do in a case like this? We have developed a technique called mandibular distraction with a curvilinear device, because the curve replicates the normal growth of the mandible. A number of studies have shown that the mandible grows in a logarithmic spiral, just like a nautilus shell in many things in nature. And you can see this growth in the mandible drawn in the lower right-hand corner of this slide. So we're going to replicate this with our device, and that involves, as you can see, placing a very small titanium device on the jaw, cutting the bone in between the two legs of this device, and then turning the little activating wire exiting out the back daily, which allows the jaw to actually grow along this curve, as you can see on the right, until we achieve a normal size to the mandible. So the distraction process uses this curved spiral distractor, which we place on the bone. The stationary segment is the part towards the jaw joint. The part with the teeth anterior to that is the part that moves and grows as we activate the device. You can see how small the device is. Here it is in my hand. They're very small. When placed on the bone, you don't know they are in there, and they're relatively inobtrusive. The process that we use is called distraction again. We generally wait a day or so after doing the surgery and then turn the device at 1 millimeter a day in children older than 4. If they're infants, we can actually move the jaw at 2 millimeters a day. What happens is when the two pieces of the jaw that were cut separate from each other with the device, new bone is formed in that gap. And so it lengthens the jawbone, and we don't need a bone graft or anything else. And in that way, it's quite superior to other methods of jaw reconstruction. Here you can see this little child after placement of the device, and I'm actually activating it, as you can see with this little wrench. And this is a relatively painless procedure, and as you can see, the child really is just not bothered by this at all. This slide shows how the device separates out. When we've completed the distraction, the activating wire is removed under a small local procedure, and you'd end up with the bottom slide, as you can see here, without the activating wire, which was present above. And so the device is on the jawbone, the jaw's been distracted. We then leave this device in for about 6 months and do a small procedure to remove it later. Why do we leave it in? Well, because the jawbone that has newly formed in that gap is still too soft to maintain a normal shape. And we've seen from a number of studies with other techniques that up to 50% of that bone is lost if you take and remove the device too early. By leaving our device in for 6 months, it maintains the stability of the bone and allows that new bone to mature and become harder, and thus we have a better long-term end result. We have a relatively precise protocol, as you can see here. We let the children start drinking and eating during this process, and their small wound dressings are done to the face. Here's this child now just shortly after jaw distraction by about 1 month. You can see the little scar on the face where we remove the ear tags as an additional procedure, and you can see he still has the right facial cleft involving the enlarged mouth. We went and fixed that at a later date. But you can see how much more symmetrical the face is at this time, and you can also see above here the polysomnogram post-op study. He had an apnea-hypopnea index of 3. This is certainly acceptable and quite a change from the preoperative one of 27. This is a 6-year-old girl. Remember, if there's not an airway issue with the infant, then we wait to do the jaw distraction depending upon how small or large the mandible is. In this case, this young lady was 6 years old. She had no airway issues, but she had a small jaw that was significant enough, as you can see when we have her bite on a tongue blade, how crooked the face is. What happens is when the small mandible grows, it doesn't grow enough, and so it causes the actual upper jaw or the maxilla on the involved side to also not grow correctly, and we end up with a very lopsided face. We want to prevent the secondary deformity to the maxilla or upper jaw by correcting the mandible, which then lets the upper jaw grow normally. Here you can see the 2 arrows indicate the difference in the mandible from the right to left side. The bottom arrow or the lower arrow being where the jaw should be, and the upper arrow how it did not grow. So we put the device on. You can see this x-ray with the device on the small side of the jaw with the activating wire, and it's collapsed at this time. And we went ahead and distracted and then removed most of the wire, and you can see the gap, how it's increased in the distance between the 2 ends. That's how much bone we did achieve, and it was roughly about 17 millimeters of bone, or 1.5 inches. Here you can see the comparison from the slide on the bottom with a collapsed distractor to that one that has been opened up on the top. And in fact, you can also see the excellent bone underlying this. And here's a little bit more of a detail shot on that, showing the difference in the length and height of the jaw and the new bone formed by this. And if we go back and look at the x-ray we showed first, there are no arrows here, but both jaws are both of the same length. So we've totally reconstructed this mandible for this young lady. And here's her face afterwards. So what's really interesting here is not only did we achieve skeletal balance, but we know from jaw distraction that with the device and distraction, the soft tissues actually grow. The muscles will grow, and the skin and the tissue underneath the skin will grow up to 15%. That doesn't happen with any other procedure. And if you wait until the child's done growing and do this procedure, that won't happen. That's one of the benefits of doing this while a child is actively growing. And you can see in this case the two very small scars that were involved in the face replacement of this. The one in front of the ear actually was an ear tag. Here's this young girl now at the completion of growth in process of having her ear reconstructed. And you can see that she's maintained a very nice facial balance during this interval after our jaw distraction. And she will need no other jaw procedures during her lifetime. What about adults? Well, this could still be done in adults, although we prefer to do it in children because the results are generally better. This 22-year-old woman was a college student and was unhappy with her hemifacial microsomia on the left, as you can see, which had never been corrected. She had some trouble chewing and a very asymmetric face. If we look at her radiographs, you can see how short the left side of the mandible was compared to the normal right mandible. She was a type 2B, which is the third most severe kind. There's only one type more severe than that, which, as I said, was the type 3. What did we do in this case? We placed a distractor here and distracted this mandible for 43 millimeters. That's 4.3 centimeters. That's a large amount, but achievable by distraction. Obviously, if we had treated her earlier, we would not have had to distract to this great extent because the jaw would grow on its own. This created an open bite, as you can see, between the teeth of the upper and lower jaw because the upper jaw obviously was affected. In this case, with appropriate orthodontic treatment, the upper jaw was allowed to grow down into make contact with the mandible and have a good occlusion. As you can see, here's post-distraction results. Here's a frontal x-ray showing the view from the front. Here's after the distractor removal at 10 months. Again, we leave it in for a minimum of 6 months to allow the bone to be stable. And you can see the excellent bone quality here. Here, just to compare pre-treatment, the right side, as you can see on your left, a normal jaw, and then the left, how small the mandible or lower jaw is when it's been outlined in blue. Post-treatment, we can see the right side and left side compared, and while the slides are a little different size, you can see that the jaw has been fully reconstructed. And this is this young woman after this surgery. The skeleton is now perfectly balanced on her face. What we see as a difference is the lack of soft tissue here because she had a soft tissue deficit also, and this was not corrected during growth, so that remains a problem and will need later corrective surgery just for soft tissue. But the skeleton itself has been corrected, and you can see that the occlusion, or the bite, in this case is now perfect. Let's take a look at a young girl through complete treatment. This is a young girl who was age 8 in this slide with a type 3 hemifacial microsomia. Remember, this is the worst. Most of the jaw is missing on that side. A couple other views of her face is showing some of the soft tissue issues. So here's what her jaw deformity looks like. In the top left pantograph, radiograph, you can see that the posterior part of the whole jaw is totally missing on that right side, and on the cephalometric x-ray on the right, you can also see more of this defect. Again, she didn't have airway issues, so we treated her later. And this was one of the early treatments also when distraction was just starting. Because there was no jaw on this side, because it's a type 3 again, we had to create a jaw and a joint. And we did this by doing a rib graft with bone and cartilage. And you can see this in place in this slide. That initially corrected her deformity. However, remember that there's a lack of normal muscle on this side of the face, and that this side of the face doesn't grow normally in spite of us placing a bone graft like we did in there. So later, this side was much smaller, so we went back at age 12 and did a distraction of this to create more bone. And you can see on the left the distractor. This is one of the first distractors that we used. And you could see it was outside the face and it was straight only. So that has some limitations. One, it's not hidden and is prone to injury. And it's also straight, which doesn't give us an ideal movement of the bone. It compared that to the very small curved distractor, which I showed earlier, which is hidden. And you can see how much these devices have developed in the interval. But on the right, you can see the young lady after this. And then again here, when she had completed growth, got around 16, we then did orthognathic surgery, which involved moving the upper and lower jaw to the correct position at one procedure to place the bones and the teeth where they ideally should be. And here you can see this young woman now with a really nice facial balance. The only deficit is that in the soft tissue, as you can see on the involved right side, there is some lack of the soft tissue leading to some facial asymmetry at the present time. But the skeleton itself has been fixed. And here she is post-jaw surgery and correction of the skeletal deformity. And what we did at this time was went ahead and corrected the soft tissue by doing fat transfer. And so here's this young lady at the beginning of treatment and at the end of treatment, and you can see the nice result that we can obtain with the most severe type of hemifacial microsomia. Again, soft tissue reconstruction is part of our treatment protocol now. A number of articles, as seen here, attest to the efficacy of this using fat transfer. When we're doing other procedures, so we don't have to add an additional anesthesia or a surgery procedure. And these children, usually 3 to 4 treatments will be needed for a total augmentation of somewhere around 30 to 40 cc's of fat. These are relatively easy to do, and they preclude larger surgeries, which many children have had in the end to transfer tissue that are much more complicated than this. In conclusion, variation of surgical approaches are required to correct the skeletal, auricular, and soft tissue components of hemifacial microsomia. I've mentioned some of them in this talk. Timing, again, depends upon the severity of the deformity, what components are involved, and if obstructive sleep apnea is present. And again, type 2B skeletal, best distracted around age 6 to 7, as long as there were not any pre-existing airway issues. Here you can see one of our young and happy patients on the left just prior to his jaw distraction, and on the right after distracting the left side of the face and removing some of the ear tags at the same time, in a combined surgery also on his internal ear by Dr. Robertson. And he was a happy camper at the end of this, as you can see, and obviously so was I. Thank you again for paying attention to this lecture, and it's been my pleasure to talk to you.